Well, welcome everybody. We're going to go ahead and do our next lever chapter, Tumors and Cysts of the Epidermis, which is quite an extensive chapter. I've gathered a lot of slides from the Path Presenter website, so shout out to them. It's very interesting cases. Check it out if you get a chance. And I think we're just going to look at many cases, and I'll give you my approach to each of these and hopefully point out the most important features to make it easier if you run into these cases during your rotations or if you're doing derm path or whatnot. So like I said, there's quite a few, so let's go ahead and jump right in. And we can start with this interesting case, number one, which it's a fairly broad biopsy. And the things I see is we have quite a bit of papillomatosis here, some acanthosis of the epidermis, bland morphology to the cells. And I would think, practicing derm path daily, I would think this is pretty good for a seborrheic keratosis. We even have some horn cyst formation here. So what happens then? There's a couple of things. You look at the requisition and you say, well, this is a child, this is an 8-year-old or whatnot. Then you're thinking, well, this is not the best for seborrheic keratosis in an 8-year-old. And then you're kind of switching your thinking, and I would have to start thinking epidermal nevus, which is what this is. So it can be tricky to differentiate epidermal nevus from seborrheic keratosis or even a verruca vulgaris, although in verruca vulgaris you can look for HPV change, and that's where the clinical history becomes so important. One thing that I have noticed with epidermal nevi is that they often have more of this kind of a papillated appearance. You can see right here, almost like a papillomatous or even a polypoid appearance, and that's because the stroma is involved in the whole hamartomatous process. And that's one of the things that kind of differentiates between seborrheic keratosis and epidermal nevus. So it can be a handy thing to know. Okay, so we'll go on to our next case. Let me flip the slide around. So fairly broad biopsy. And again, common things. Commonly, I would look at this and think, kind of looks like an epicyst right there. But there's more going on, right? A little more interesting than that. We have over here what also looks like similar appearing epidermoid cysts. We can zone in here and see that there's laminated keratin, there's an epithelial lining. It looks like an infundibular or epidermoid cyst, but there's multiple, and they're all opening up to the surface. So after I've made that assessment, I would look at the requisition and I'd see that this is something that's occurring in a linear configuration. Maybe it's on the palms and soles. I mean, that would be a kind of a warning sign that, that's something's not quite right for an epidermal cyst to occur on the palms and soles. It's a little weird. And it's a younger patient maybe. So this is actually a nevus comedonicus. And you can see how it resembles in many ways a dilated pore of Weiner. And some people actually think that this might be a subset of an epidermal nevus syndrome. But it's fairly distinctive. I remember just epidermoid cysts, multiple, many of which open up to the surface, like this field here, which we're seeing right here. Okay, we'll go on to their next one. This is a smaller biopsy now. It's a punch. So we zoom in on here, and we can see not much going on at low power. I might think this is actually a younger patient just because of the appearance of the collagen here. We got lots of these eccrine glands, not 100%. So we want to make sure we scan all of our epidermis here, and we can see these little structures here and here. And so I would start thinking, well, this kind of resembles a little bit of a cornoid lamella, so I'd start thinking of a porokeratosis here. And actually, as we look at the requisition or get the more clinical history, we find out that this is on the hands, maybe the feet, and this is in a linear distribution, and it's maybe a younger patient. And these are what I thought were cornoid lamella at first, actually look like they may be associated with these eccrine ducts. So this is actually pretty good for porokeratotic eccrine osteal and dermal duct nevus, which is a very rare thing. And maybe I think I saw one case so far in my career. But I think the shortcut to this is if you see something that kind of looks like a porokeratosis, but you get the history and you start to see that these structures are actually aligned more with these eccrine ducts, you have to rethink how you're approaching this, get a more specific diagnosis. and get to porokeratotic ecrine osteoendermal duct nevus. It's really an ecrine hamartoma, and as I've said a few times already, this really mimics porokeratosis. All right, we'll go on to our next one. So our next few cases actually are kind of grouped together in a sort of interesting way, which I'll get to in a minute. So here we have a shaved biopsy, lots of hyperkeratosis. And we go in closer here. And this is actually one of these reaction patterns that I think are very important to recognize because they're so common. And again, like I've been saying, it needs a lot of CPC. So what do we see here? We see a lot of hypergranulosis, kind of gringy hypergranulosis, and sort of this vacuolization of the upper layers of the epidermis. Really good for epidermolytic hyperkeratosis, which is this reaction pattern. So whenever I see this, first of all, most of the time when I see it, it's actually an incidental finding. But if it's like this and it looks like it's right in the center portion of the biopsy, it's probably what they were seeing clinically. So I want more history because this pattern can occur in a variety of syndromes, epidermal nevi, keratodermas, or in this case, which is a solitary lesion, solitary keratotic lesion called epidermolytic acanthoma. And that's what this is. It's actually a pretty good example. Not a very common thing, but we do see it every once in a while. And I think the important point is to recognize, again, this reaction pattern. Here's another one where a reaction pattern becomes important. A punch biopsy on this one. We'll go ahead and flip the slide around. And we see a couple of foci in the epidermis that jump right out to us. A little bit of sort of a parakeratotic plug. And if we go closer, we can see that the epidermis is kind of falling apart right here. This is acantholysis, actually. And acantholysis is sometimes associated with these dyskeratotic cells, which the big round ones like these down here, I would call corons. And the ones that are up here more like sort of look like little pieces of rice are the core grains. So this reaction pattern is acantholytic dyskeratosis. And again, most of the time we see it incidentally, but you can see it in association with various syndromes: focal acantholytic dyskeratosis, Grover's, Darier's, warty dyskeratoma, even things like Galli-Galli, Haley disease. Although Haley disease is one where you see more pronounced acantholysis and less dyskeratosis. Kind of looks more like on the pemphigus side. And as a matter of fact, I can jump right into this next slide, which, if I didn't know anything, I would actually think about Haley disease. There's again the same pattern of acantholysis, although we don't have as much of the dyskeratosis. We're much more on the acantholysis side versus the dyskeratotic side. And I would think about Haley or maybe pemphigus in this case. But this is actually a solitary lesion. So if it's a solitary lesion, keratotic lesion, which the clinician would tell us, and then you go more down the road for acantholytic acanthoma, which is the name I would give this thing. So two examples here of a focal acantholytic dyskeratosis, which is more of the dyskeratotic side, and the acantholytic acanthoma, which is more of the acantholytic side. So I know that's a lot. I kind of tried to summarize that right here. You can see both epidermolytic hyperkeratosis and acantholytic dyskeratosis are reaction patterns. And I think the important thing is they can occur in a lot of conditions, but they can also be solitary lesions or incidental findings, which is sort of what we're dealing with in this lecture right here. So you can look at all of these different conditions, and as you do more and more derm path, you start to see that these are common patterns, and it becomes very handy to know these because they can be very good, very handy in board situations and daily practice and whatnot. All right, so we'll go ahead and switch gears. This is actually from the oral mucosa. I don't have too many cases from the oral mucosa because probably won't see too many of those. We certainly don't, but this one is so distinctive, I thought it was worth mentioning. So we can see we have thickened or acanthotic epithelium here. And what really jumps out is this central area right here. Very, very distinctive contrast to the adjacent epithelium, very clear cells. And again, we find out that this is a younger patient, maybe a child. This is a nice example of a white sponge nevus, a very characteristic look to this. Here's some notes I made on that. benign autosomal dominant condition, often on the buccal mucosa, involving possibly keratins 4 and 13. And this hydropic swelling of keratinocytes is what really does it. So it's a nice one to kind of keep in the memory banks because although you won't see too many biopsies from the oral mucosa, this one's very distinctive. One more again from the oral mucosa again. We'll go ahead and flip this over. So I look at this, I know it's oral mucosa. I look at the requisition for the site and I'm thinking, well, this is a little strange for that because you got these elongated, almost like psoriasis-like look to this, elongated, what looks like reedy ridges, which you really don't usually have in oral mucosa. As you scan around a little closer, you may see this right here, neutrophils within the oral mucosa. So you can, similarly to how you would do it in regular skin, you can think about neutrophils, the differential diagnosis of neutrophils in the epidermis or epithelium. So you want to rule out your candida, your tinea, psoriasis, maybe syphilis, and impetigo. But you get more clinical history and you find out that this is maybe a solitary lesion, a whitish appearance, a nice example actually of geographic tongue. I've seen a couple of cases of this actually, so not entirely unheard of. And it really just looks like psoriasis. And some people really think that this might be a variant of psoriasis, although that's kind of controversial. But it certainly histologically, I think, has that appearance. It's really those neutrophils and that sort of elongated psoriasiform acanthosis elongation of the reedy ridge that does it. Okay, so we'll move on. So this case, if I had to use one word to kind of describe what's going on here, would be endophytic. And this is endophytic if I've ever seen endophytic. I mean, this is really a downgrowth, kind of a bulbous architecture at the base here, kind of a symmetric overall appearance at low power. So I think it's a benign lesion. It looks keratotic. It's formed by squamous cells. And as we kind of zoom in, we can see that we see these structures right here, which is very handy to see actually. These are a very nice example of squamous eddies. And whenever I see squamous eddies, I'm very reassured because it's, I know it's going to be a benign condition. And so these squamous eddies plus this downward growth or endophytic growth is really good for an inverted follicular keratosis, which is what this is. There's sometimes this talk of what's the difference between squamous eddies and keratin pearls. I'll actually talk a little bit more about keratin pearls later. But in general, squamous eddies have very bland epithelium. They're small, they're very round, and pretty unusual for them to have any kind of a real keratotic core. Maybe a little bit right there, but no real good parakeratotic core, which is what you see in keratin pearls, which we'll talk about. So here's another example. And this, again, this one is sort of reminiscent of just a keratosis, either a seborrheic keratosis or maybe a wart. And some people think that these may be related to that. But the two things that you want to see to call it an inverted follicular keratosis is at least some inverted or endophytic growth, and for sure the squamous eddies, which are again nicely represented here. All right, so we'll keep going here. So I'm kind of following the order of the lever chapter. So if you want to follow along in the book, you can do that. So here we have, excuse me, here we have what I would at low power, similar to the very first case we saw, say, hey, this looks a lot like seborrheic keratosis. We can even see some pigmentation at low power, that sort of stuck on appearance. Not really much horn cyst formation, although maybe around this side over here it's starting to. But there's got to be something more to this. So we look closer and the pigmentation is really starting to jump out. And if we look even closer at higher power, we can see that kind of intermingled between these keratinocytes are these melanocytes that have this very dark pigmentation. And maybe, hopefully it's not too hard to see in the presentation, but these dendritic processes that kind of make their way in between the keratinocytes. So this combination is pretty good for melanoacanthoma, which is what this is. I got a PowerPoint here. So you get melanocytes, often dendritic, intermingled with keratinocytes, and it's a very pigmented lesion. It's a dark, dark lesion. So that's what we typically see, and I think that's pretty nicely represented here. Let me see if I can go to another area to maybe have those dendritic melanocytes a little bit better. hopefully they can see them throughout here. It can be a little bit difficult to see, but this area is pretty good and throughout here. So I think this is kind of like a seborrheic keratosis with a superimposed benign melanocytic component to it, and it really imparts this very dark appearance to it. Okay, so we get to this next case now. And what I would say, if I saw this most commonly, is what I would associate this with is skin tags. I mean, very simply, they just look like a bunch of skin tags. I would think they're coming from the axilla or something. But then you find out that this is actually from the face of maybe a darker skinned patient. And then you know that this is actually dermatosis papulosa nigra. It's a very, very common condition. We see it occasionally biopsied, often for cosmetic reasons. And some people think this might be a variant of seborrheic keratosis. I can kind of see that because some of these look like they have that sort of papillation and even a little bit of horn cyst formation. But the easiest way to recognize it histopathologically is all these things that just look like a lot of skin tags at low power. All right, keep going. So this is an interesting condition, I think, that's probably under-recognized in practice. And sometimes I see this and not sure what to do with it, but I'll kind of walk through it. So we see a shave biopsy and on kind of a normal looking hyperkeratotic scale, and maybe some elongation, not much thickening of the epidermis, but I think some of these reedy ridges may be pointing a little bit. So low power scanning at this power, I would think, this kind of looks like a lot like a solar lentigo. Maybe an actinic keratosis, although actinic keratosis, I would think probably not, just because it's such a hyperkeratotic laminated keratin. You don't really have the parakeratosis that you associate with actinic keratosis. So you go closer and you see some of these cells, at least the ones confined to the lower portions of the epidermis, are fairly large, at least in comparison to the more superficial cells. So this is actually pretty good for a large cell acanthoma, which we don't use the term very often. And in fact, some people, again, common theme today, think that this is a variant of seborrheic keratosis or a lentigo. Often the differential diagnosis in daily practice is with actinic keratosis because you can't have pretty large cells. Let's try to go to this next one. That make you think that this is an atypical thing. But it's really, without the parakeratosis, I'm really reluctant to call something an actinic keratosis. And these large cells actually, they're larger, but they're not really atypical. They're not pleomorphic. They're not jumbly. They're just larger. So the name is pretty good, large cell acanthoma. So you may see this on your exams. Nice to know and recognize it. And this one you almost certainly see on your exams and in practice when you do your rotations. We'll walk through this one. So again, similar to what I was talking about earlier, a very psoriasiform pattern, regular psoriasiform pattern, elongated reedy ridges, all kind of at the same level. That makes me think regular psoriasiform thickening. And there's something to the quality of these cells that's kind of different. It's the easiest to tell if you have normal epidermis, which we do at the edge here. You see the difference between this and this, much more pale cells over here, or clear cells. And then you may see a few neutrophils in the scale, not always, but sometimes you can catch a few neutrophils. When I was training, I used to think that I used to mistake this for psoriasis actually. But this field right here is really the key. You see this sharp demarcation between the normal epidermis and the lesion, which is a clear cell acanthoma. You probably know by this time. Not an uncommon thing, often on the legs of patients, and you can actually have multiple of these. So it's most of the time we see them solitary, but if you get the requisition and it says multiple lesions, that's still okay for clear cell acanthoma. This one actually has a much nicer example of the neutrophils within the parakeratosis. Again, I used to mistake this a lot for psoriasis. If you do a PAS stain, you may kind of highlight this pale cell quality or clear cell quality as it's glycogen. And yeah, this is definitely one you'll see. I see this maybe about once a month, twice a month. So it's a good one to know. All right. So we got our common cysts, what I call our common cysts, which I'm not going to cover too much detail because we see them all the time in practice. And so you'll be very good at recognizing these, but this is an epidermoid cyst, which we know and love. And I'll just go ahead and say that one of the handy ways that I've learned to distinguish cysts, and we'll cover different, more rare cysts in a little bit, but one of the handy ways is by looking at the contents. So at low power, you can see this is what I call laminated keratin, with this kind of shredded wheat appearance to it. Often you hear residents saying, well, is there a granular layer? Is there not a granular layer to tell the difference between epidermoid and pilar cysts, which is true, but I think it's much easier looking at the contents. These are also called infundibular cysts, as they are formed from the infundibular portion of the follicle, which is almost embryologically identical to the epidermis anyway, so that's why it really just looks like epidermis. So we won't cover too much more on that, except for noting the contents, which if you look at our next thing, which is a very common cyst that you'll see in daily practice, our pilar cyst, you see the nice contrast. So as opposed to that shredded wheat or laminated keratin, we get a much more homogeneous keratin or tricholemmal type keratin, which is what we see in pilar cysts. And these much more commonly will calcify. This is what we're seeing right here. And yes, it is true also that you do get more of this abrupt transition to the keratin with really very little to no granular layer. That's all I'll say about those common cysts, except for one variant here, which is interesting. Again, we see fragments of skin here with a cyst right at the periphery over here. And if you look at some areas of the keratin, it's a little more compact, but I think it is still that laminated kind of quality. It's just a little bit more compacted compared to what we usually think about for epidermoid cysts. But I think it is still compact or compact laminated keratin. The difference is that we have the epidermis, which is much thicker here. And if you zoom in on this area, this portion of the cyst wall, a lot of hypergranulosis and even some parakeratosis, which is unusual for an epidermoid cyst. And if you didn't know anything, if you just had this field right here, I would think of a wart. I would think of a verruca vulgaris. You know, you got the verrucous kind of architecture, you got the hypergranulosis, you got the parakeratosis, maybe even some coilocytic change right here. So this is a variant of an epidermoid cyst, a verrucous epidermoid cyst, which has its HPV change within the wall. So that's really all it is, epidermoid cyst with HPV change. And you can get your verrucous epidermoid cyst. And there's all sorts of HPV variants which are associated with this, which I won't go into. You can look those up if you want. Okay, here's another, switching gears now, another very common thing that we've already talked about, very easy to recognize with that stuck-on appearance, that epidermal thickening, and tons of horn cysts. This is our very, very common lesion, which we know and love, our seborrheic keratosis. So I'm going to just cover a few of the variants because I think that's probably better because we'll see a lot of these. So this is the more conventional one. And changing to this slide, we'll go into a little bit of a different kind. Zooming in, you can see that this has still areas which look like sort of the conventional seborrheic keratosis, which with the epidermal thickening, maybe a little papillomatosis, the horn cyst, but much more of this kind of elongated reedy ridges, internastomosine reedy ridges. So this is what I would call a reticulated variant of a seborrheic keratosis. And you can almost imagine that this maybe had, it started off its life as a solar lentigo and eventually grew up to become a reticulated seborrheic keratosis, because these really remind me of what you would see, much more exaggerated, of course, but what you would see in a solar lentigo. So you can use the term reticulated or net-like to describe that. This is a particularly good example. Often we'll see examples of this, but it may not be as pronounced. Here's another variant of a seborrheic keratosis. Not immediately obvious at lower power because it's a fairly thin lesion. We do have some more conventional areas of seborrheic keratosis with horn cyst formation, but then we get these intraepidermal, what I call clones, or these little round nests of what are actually keratinocytes. As you get more experience, you start to wonder, how do you tell the difference between seborrheic keratosis, clonal type, which is what this is, versus squamous cell carcinoma in situ. And it's a matter of squamous atypia, degree of atypia. And so these don't have overlapping nuclei. These don't have jumbling, no real high mitotic activity. So it's much better for a clonal seborrheic keratosis. There's a term, the Borchiadison phenomenon, which you can think about for this pattern right here. And when you see this Borchiadison phenomenon, which is sort of this clonal pattern, seborrheic keratosis, clonal type is one thing you think about. Eccrine poroma, which was on the PowerPoint, you can also think about, but even squamous cell carcinoma in situ. Those are like the three things in the differential diagnosis that I think are important. But again, because this one has classic areas of SK and sort of this very bland cytology, we can land our diagnosis at clonal seborrheic keratosis. All right, so as I said, we'd be kind of switching back to cysts. So we're going back to the more unusual cysts, which I think are a little bit more interesting. So here we have a very kind of convoluted cyst, and sticking with the same approach I was talking about earlier, there's really not much of cyst contents here. Maybe a few little like frothy cyst contents, but you don't have the laminated keratin. You don't have the homogeneous keratin. So right away, you know you're dealing with some sort of a different type of cyst, and also the fact that it's so convoluted and complex appearing. So then we kind of look a little closer here. You can see a couple of things going on here. First of all, you see that there's these sebaceous units in the wall, which is interesting. And you also see that if you look at other portions, you have this sort of eosinophilic layer to the wall right here. So by now you probably know that this is steatocystoma multiplex, which is multiple cysts actually, can be inherited as an autosomal dominant condition, often located on the chest, axilla, or arms. And those are the three things I use to kind of make the diagnosis, what I talked about, this sort of absence of any real contents, the sebaceous units, and that eosinophilic lining, which is so characteristic for this. Some cases you can have, I'll get to it actually, but in some cases you can have even some vellus hair cysts, and there's a question about whether there's overlap between steatocystoma and eruptive vellus hair cysts. We'll talk a little bit more about that in a bit. Here's another steatocystoma multiplex that has much more pronounced sebaceous glands here, not quite as complex as the last one that we saw. But again, no contents really, maybe a little bit of frothy stuff. And then that really nice eosinophilic layer right here. Here's the summary. These are the things I was just talking about. Chest, arms, and axilla, the inner eosinophilic layer. And one thing that's not on the slide that is in this case right here is very interesting. Something you all will occasionally see with steatocystoma is that these vellus hair cysts, these things right here. So we'll talk about the eruptive vellus hair cysts in a little bit, but just know that you can see them in steatocystoma multiplex. This also happens to have a very nice, well-developed eosinophilic inner layer, and of course the sebaceous glands here in the wall. Okay, so now we'll go on to the next case, another cyst. And so this cyst, I would think fairly deep, almost down into the fatty tissue over here. And again, at low power, first thing I like to look at is the contents. And it looks like to me laminated keratin, kind of got that shredded wheat appearance. So I would start thinking of epidermoid cyst. But then you look around a little closer and sort of similar in appearance to steatocystoma, we got these sebaceous glands, but they're also associated with follicles right here. So these are like little mini follicular sebaceous units that are attached to the cyst wall. And then you find out that this is actually maybe a child, a kid, a younger patient. And anatomically, this is at either the lateral angle of the eye, midline forehead, neck. And then you have to change your thinking. This is not an epidermoid cyst. It's actually a dermoid cyst, which is similar in appearance, but different in the ways we just mentioned. And here's our little PowerPoint showing the difference between epidermoid cyst and dermoid cyst. There's the anatomic location, which can be a very good clue to pick up on. And of course, you got your hair follicles and sebaceous glands, which is what I mentioned. Okay, so now we're going to move on into our really unusual cysts, the ones that maybe had one or two cases or maybe no cases in my career. Again, same approach, no real contents to this one, and a very kind of bland, thin lining here. It's hard to tell at this power what it is exactly, but if we go closer, we can start to see this is not squamous, so that's different. And it's kind of got that more cuboidal look, actually, or columnar cuboidal look to it. It's more like almost glandular, I would say. And even a hint, a little bit of right here, cilia. So this is what, if you do surge path, you become pretty good at this, but we don't see this too much in derm path, pseudostratified columnar epithelium. And in some cases, even you can get goblet cells, which I may have to search around to find them here. And you also see one other thing. You'll see a little bit of smooth muscle in the wall. So this, by now, you may have guessed it. This is bronchogenic cyst. We don't see it very often. Sternal notch is kind of the classic location for it. And as I was saying, you get that pseudostratified epithelium. Sometimes you get the goblet cells that are kind of thrown in there, which I still haven't found a good one. But even without the goblet cells, I think we got our diagnosis. Smooth muscle or mucus glands can sometimes be present within the wall as well. So that's the other thing. And a lot of it is anatomic location, because if you see it sternal notch, often you're just kind of primed. You're thinking, even without seeing any of the histology, if you hear a cyst sternal notch, you're kind of starting to think, well, could this be a bronchogenic cyst? So this is a good example of that. Here's maybe a few of these goblet cells right in here, actually. Not as many as I would like to see, but they're there, I think. All right, so we'll move on to our next one, which kind of has a similar sort of appearance to it. And we look here. Our close up into the lining is very similar to what it was in the bronchogenic cyst. We have that pseudostratified, maybe ciliated appearance, no contents, as we were saying earlier. And really the kicker for this one is what's in the wall. You may have a smooth muscle in the wall of the bronchogenic cysts, maybe mucus glands, but in this one, you have these guys. Very, very nice example of these thyroid follicles. So this is midline located, and this is a nice example of a thyroglossal duct cyst. And this is really what you need to see for this. So you haven't seen too much thyroid. It's fairly distinctive. You have these little thyroid glands with this eosinophilic material, and it's very, very easy to recognize once you've seen one or two of these. So as long as you have those in the wall, you know, the rest of this looks very similar to bronchogenic cysts. So use anatomic location and use what's in the wall to distinguish the two. Okay, so here's an even rarer one, a cyst. This is actually located on the legs, and often in females. Again, no contents, but similar sort of appearance to the epithelium that we were seeing in some of the other cases. This pseudostratified epithelium, maybe a little bit of ciliation going on. So this is, and as a matter of fact, this epithelium resembles a little bit of fallopian tube. So this is what's called a cutaneous ciliated cyst, and it's a very unusual cyst. Location, again, helps with these. It's kind of an ongoing theme with these unusual cysts. And the epithelium for all these ones I've been talking about seems to be pretty common, or pretty common among them. You have that pseudostratified with the ciliation. So good one to know. We may see in one of these occasionally. All right, and yet another cyst that's unusual. This one, again, content-wise, having this sort of non-specific kind of frothy material. And this is another one where the epithelium may not look entirely familiar to you. I don't see it too much in daily practice, actually. And it's got a name that I think is quite adequate for this. It's not quite mucinous epithelium like what we've been looking at, and it's not quite a skin epithelium. It's somewhere in between. So it's like a transitional type epithelium. And this, in this case, anatomic location is really going to help you. This is biopsy from the penis. And a cyst on the penis, you have to think about median raphe cyst of the penis. And you have some notes here. Young adults on the ventral aspect of the penis, pseudostratified columnar or transitional epithelium. And the transitional epithelium really resembles that of the kind of the urogenital tract or the urethra. Again, it's something that if you've done surg path, it's very handy, but you won't see it much in derm path. And it really looks like this area over here, where it's not quite epidermal, but it's not quite glandular either. So again, this is one where anatomic location will, of course, be very helpful. Aren't too many types of cysts are going to occur in that area. You get epidermoid cysts in the genital area and scrotum, but ventral aspect of the penis, you have to think about median raphe cyst. Okay, we'll move on to this, yet another cyst. This is actually, I think, our last one. Let's see if we can flip the slide around. Okay, so here we have another cyst that's within the dermis. And this one, the contents really do help you, very much so, and it gets you to the diagnosis. You see all these tiny little vellus hair follicles. So this is a nice example of a vellus hair cyst. And we saw this before when we were talking about steatocystoma. But in this example, you get them much more pronounced, and you see them very distinctive, very easy to tell. If you are looking at this under a light microscope, you can actually flip the condenser, and these are very nicely refractile. So that's one little tidbit that you can use. And the wall is fairly nondescript, kind of just regular epithelium. So this is a nice example of eruptive vellus hair cysts. Follicular papules on the chest, similar to anatomic presentation to steatocystoma. And you get these retention of hairs, often in younger patients, and this kind of relationship to steatocystoma is controversial, I guess I would say. Okay, so now we're going back to reaction pattern again. And this is a biopsy that has a pattern that we've already talked about and should be fairly familiar by now. You have this nice acantholysis, which is represented in these areas right here. And you have pretty good dyskeratosis as well. Earlier, I was talking about the corons, which are these dyskeratotic cells, these larger ones here near the base. There's some good ones right there as well. And you have the grains as well, which are these sort of long, thinner ones that resemble grains of rice. So this is acantholytic dyskeratoma. And as I said earlier, you want to get, acantholytic dyskeratosis. And as I said earlier, you want to get the history. You want to know, is this a solitary lesion? It looks like it's right in the center. It basically occupies the entire biopsy. So in this case, it's probably what they were seeing. And of course, yeah, you do get the history, and this is a solitary lesion. So this is what we can call a warty dyskeratoma. So warty dyskeratoma, we do see, I mean, they're fairly common. We'll see a couple a month. And two things, you have the acantholytic dyskeratosis. Again, that's why it's so important to recognize these patterns. And you have this endophytic growth as well. So those two things in the clinical context of a solitary lesion. And then you got your diagnosis of a warty dyskeratoma. Made a few notes here. Solitary lesion, often on the head and neck. And again, our pattern is that of acantholytic dyskeratosis. This is the same differential that I had listed before in the earlier slide. Okay, so now we're moving on to another thing that's very common, like what we were talking about with the epidermoid and pilar cysts. This is an actinic keratosis, and I thought maybe it would be better to present the more kind of interesting variants. Although I will go over the important features, salient features of actinic keratosis, but you'll see so many of them on your rotation that they'll become kind of second nature after a while. But you want to see three things really. You want to see parakeratosis, and parakeratosis in particular that spares these adnexal structures. So you see a nice eccrine duct right here, and maybe a follicle right here. It looks like maybe a folliculosebaceous unit right there. You see the parakeratosis kind of stops, and you get hyperkeratosis, and it picks up on the other side. So you can often get to your diagnosis of actinic keratosis just based on that. It's a very handy clue. So that's one thing you want, parakeratosis. You want a tibia that's confined to the basal layer. You don't want it to be full thickness because then you're dealing with Bowen's disease. And of course, as the name implies, actinic keratosis, you want to have your solar damage. And we have all three of those elements right here. So a very common thing that you'll see in practice. So we'll move on to this case. which is an actinic keratosis that just happens to have a lot of hyperkeratosis here. So sometimes we'll use the term hypertrophic actinic keratosis, which I think would be appropriate here. But you do see still the important features that I was talking about. Those are retained in all actinic keratoses. So you see this very nice sparing of this eccrine duct right here and this eccrine duct right here. Maybe some sparing. I think there's a follicle right here, so you can see that sort of sparing. And this picture right here is so characteristic to be able to identify something as an actinic keratosis, sometimes in cases where the biopsy is not the best or it's not as obvious. And of course, your atypia confined to the basal layer and your solar damage. So I'll move into a couple of the variants of actinic keratosis. So this is another 8K. Again, at low power, you can sort of see that alternating scale of parakeratosis and hyperkeratosis. And we see our atypia confined to the basal layer here. We also have a little bit of acantholysis. So acantholysis is a pattern we were just talking about. And one of the things that probably should add to this is that you can have actinic keratosis that has an acantholytic pattern. You can see it nicely represented right here. Not uncommon at all. I see a lot of AKs that have at least a little focus of acantholysis or this kind of falling apart. And it's usually within the areas where the atypia is, so usually within the lower portions of the epidermis. So that's a good example of acantholytic actinic keratosis. And here is another variant of actinic keratosis. I see this biopsy, I'm thinking band-like lymphocytic infiltrate. Band-like lymphocytic infiltrate, so lichenoid. And most of the time when we see lichenoid infiltrates in daily practice, we think benign lichenoid keratosis. Maybe you can think about the lichenoid differential diagnosis inflammatory patterns. But you want to look at your epidermis, make sure you're not dealing with something else. And indeed, we do have the parakeratosis here, kind of alternating a little bit, more or less, with hyperkeratosis. And I think we have pretty good atypia here, actually, confined to the basal layer. So we have all our criteria, the solar damage, to call this an actinic keratosis. And the fact that we have superimposed band-like lymphocytic infiltrate adds up nicely to a lichenoid actinic keratosis. That's one of the variants that you can see. All right, so now we'll really change gears. Again, we're following the order of the lever chapter, but this one, we're going back to the oral cavity, and this is just an interesting one because I think it's something that if you ever see, because of the features, which are fairly distinctive, you should be able to make a diagnosis fairly quickly. So this is oral cavity. We can tell this is oral mucosa here. We have some skeletal muscle as well. So it's one of the places, the oral cavity, where you can get skeletal muscle, a few of the places. And we have an ulcer. We have a very large ulcer here. And we have kind of the things that you usually see with ulceration, maybe a granulation tissue reaction. That's kind of the mid layer right here next to this, underneath this fibrinous ulcer. Now, what I usually like to do is make sure you're not dealing with a couple of things, infectious, in particular herpes, or tumors. And often at the edge, you look for inclusions, which are absent here. So I don't think that's what's going on. But then I like to go to the composition of the cells. And what's unusual about this is that there's quite a few eosinophils. Eosinophils are typically not something that you would associate with ulceration, not in great number like this. So this is actually the tongue, and this is actually eosinophilic ulcer of the tongue, which is an unusual condition. Probably not going to see too many of these, but again, easy to recognize because of the ulceration, because of the anatomic location. Again, the oral squamous epithelium, and then the skeletal muscle that we associate with the tongue, and the eosinophils, of course, which kind of give it its name. It's good to recognize this because you can give it a name, you know it's an often asymptomatic condition, and you know that these often lead to just spontaneous healing. So it's good reassurance for the patient. Okay, moving on. So here we have a shave biopsy. Now we're going back from pretty uncommon to pretty common. And I see in this shave biopsy a very, very striking kind of parakeratotic and hemorrhagic scale. So I'm thinking that this is an atypical lesion because there's something wrong with either from inside out or outside in. There's too much scale here. And as you go in closer, you can see, even at this power, low power, I think the epidermis looks very blue or purple, maybe, too much so than what you would associate with normal epidermis. And it's much more thickened too. Sometimes it's nice to see, to compare areas that are normal, which is right here. You can see this is kind of a normal color, normal thickness. And here's our abnormal area, which has much more thickness to it and this really dark quality to it. And as you go closer, this is what I was talking about earlier, overlapping and pleomorphic nuclei. This is very nicely represented here. So this is our Bowen's disease, very common. We're not going to be talking too much about this except maybe some of the variants because you see a lot of these. And this is a very abnormal process. You can see overlapping nuclei, as I was saying. No problem recognizing nuclear pleomorphism, hyperchromasia. And sometimes these apoptotic bodies, these scattered dyskeratotic cells, are a nice clue as well. So full thickness atypia, you get less sparing of the adnexal structures compared to an actinic keratosis. This thing kind of just bulldozes over everything, and you have atypia from one side all the way to the other. So that's one thing you can use to distinguish the two, besides from the obvious full thickness atypia. Here's a more verrucous variant. You can see a little bit more of this verrucous pattern to it, but nevertheless, you still have that nuclear hyperchromasia and pleomorphism at all levels of the epidermis, plus atypical keratinization. You got parakeratosis pretty much throughout the whole thing. Nice contrast here between the normal and the abnormal areas. So if you have a different anatomic location, you might give it a fancier name. There's lots of names in derm and derm path that we like to give things. And this is one that has the same really appearance of what we were talking about earlier, Bowen's disease, the same full thickness atypia, and the same sort of purplish, bluish quality to it, and even the parakeratosis, with the exception that this is from the glans penis. So this is given the name erythroplasia of Curat. And it tends to occur in uncircumcised men, and there's a possible relation to HPV. So it's important to recognize it as one of the variants of squamous cell carcinoma in situ or Bowen's disease. Those are terms I use interchangeably for these, by the way. I think most people do as well. Okay, we'll keep going. So here is, again, we haven't left the location, so we're still in the genital area. But if you look at the epidermis in this case here, it doesn't look as bad. And there's a lot going on underneath, which we'll get to in a minute. But the actual epidermis, I think, looks atrophic in some areas, not thickened. And even in the areas where it's not atrophic, it looks pretty bland. You don't have that nuclear hyperchromasia, pleomorphism, overlapping nuclei that you had in squamous cell carcinoma in situ. In some areas, you may have a little bit of a flatter epidermis, like what we were talking about. Get this straight here. And you may have an appearance of some of these sort of like diamond-shaped or lozenge-shaped cells. That's quality I've always had difficulty appreciating. But I think if you look at a few of these over time, it becomes a little bit easier. The thing that's not difficult to appreciate is this very brisk band-like lymphocytic infiltrate, which has a lot of plasma cells. So by now you probably got the diagnosis. It's a nice case of Zuhn's balanitis. Very good example of plasma cells, a nice eccentrically located nuclei, the perinuclear Hoff, a very purplish cytoplasm. Hard to appreciate the clock face chromatin, but nevertheless very easy to appreciate all of the plasma cells even at that power. So it's a nice example of Zuhn's balanitis or balanitis circumscripta plasmacellularis. Benign condition, often in uncircumcised men, and really unknown etiology, probably some sort of a reactive process. But I think the important thing, a couple of things, it's to recognize that it's not cancer, that's not squamous cell carcinoma in situ. You can tell that by looking at the bland epithelium, by those lozenge cells. And if you have plasma cells, you often want to think about syphilis. So you may want to check with, correlate with the serologic studies or do a spirochete antibody stain. Here's another example. This one not quite as atrophic, the epidermis not quite as atrophic as what we were seeing in the last one, but nevertheless very bland epithelium. And not as many plasma cells here, but they are there. If you zoom in a little bit more, you can tell that the majority of these are actually plasma cells. You can see them nicely right there. So here's a quick summary of what we were just talking about, unknown etiology, and thin or flattened epidermis. Both cases that we saw, I think, represented that pretty nicely. Okay, so again, going back to sort of bread and butter from the less common to the much more common, this is our nice squamous cell carcinoma. And again, I'm not gonna, you'll see tons of these, so we're not gonna talk too much about all the intricacies of squamous cell carcinoma, except maybe keratin pearls, which I'll talk about in a minute. But we will talk a little bit about the variants because I think they're more interesting and more relevant for our purposes. So you're infiltrating irregular islands of squamous cells and nice desmoplastic stroma. No problem here recognizing atypical variants here, atypical cells, sorry. And this example right here actually had really nicely, has really nicely represented keratin pearls. So I promised I would talk about this. So we saw the squamous eddies from before, which I said were smaller, rounder, blander epithelium, and are not typically associated with keratotic or parakeratotic core. And that's in stark contrast to what we're seeing here, these keratin pearls right here. This is what I like to use, is these parakeratotic cores that are fairly large and surrounded by these highly atypical cells. I think they're easier to spot when you have those parakeratotic cores. Here's another example over here. So if you ever wonder what those are, I think pretty nicely represented here. And again, no problem determining atypia here, this really jagged angulation of these squamous cells. You can imagine how this would quickly become, if left to grow unchecked, very, very ugly and dedifferentiated or poorly differentiated, and be difficult to even recognize as squamous cells. And I'll talk a little bit soon about that. So a good example of keratin pearls. Here is another variant, histologic variant. So it's just like you can get acantholysis in actinic keratoses, you can get acantholysis in squamous cell carcinoma, invasive squamous cell carcinoma. And this is really nicely represented here. We have these falling apart of cells. The difference is you have a malignant growth, right? You have downgrowth of the highly atypical cells into the dermis. So this is pretty easy to recognize as squamous cell carcinoma. And it used to be when I was training, that they thought these had a more aggressive biological behavior, although that I think is not the case anymore. So we can report it in our microscopic description, but as far as it making a difference, probably doesn't. But good to recognize at least. Don't be fooled into calling this something inflammatory. So acantholysis is, you may think of it as an inflammatory pattern, but it can occur in neoplastic processes. Okay, as I said earlier, squamous cell carcinoma can get pretty poorly differentiated and almost impossible to recognize, which is what we're seeing right here, actually. If I had this biopsy, it's a shave biopsy, probably from sun-exposed areas, some solar damage there, maybe an older patient, probably an older patient. I would really start going down my atypical fibroxanthoma or AFX differential diagnosis. And what that means is that you have to start using your broad markers. So you have to use your broad keratins to rule out squamous, spindle cell squamous cell carcinoma, your melanocytic markers to rule out melanoma, maybe your smooth muscle markers, although that's not typically the first thing we think about. And of course, your atypical fibroxanthoma, which is kind of a diagnosis of exclusion. And really, there's nothing here that I could use to be able to tell that this is a squamous cell carcinoma. I'd really have to rely on our markers. We typically use cytokeratin 5/6. Some people use P63, P40. We've had our best experience with cytokeratin 5/6. But really not much even connection to the epidermis. So it's a fairly tricky one to be able to identify really ugly cells, which make me really think about atypical fibroxanthoma. But in this case, I'm sure the immunohistochemical studies were done and shown that this was a poorly differentiated squamous cell carcinoma. There's pleomorphism if you ever saw one. Here's another variant of squame. So we have no problem recognizing this as squamous cell, given this aggressive growth over here, areas like this, where it looks squamous cell carcinoma, but tons of clear cell change. And clear cell change is something we do see in malignant processes. Most of the time, I feel like I see it in squamous cell carcinoma in situ. This is pretty extensive clear cell change that we're seeing in this squamous cell carcinoma, invasive squamous cell carcinoma. But just know it can occur. It can occur, and it's probably some sort of glycogenation that's going on that's causing the clear cell change. Interesting case there. Here we have a squame that is actually invasive squame right here that's actually arising in association with squamous cell carcinoma in situ. And the in situ component is showing a little bit of this pagetoid pattern. We have individual atypical cells imparting this upward scatter or pagetoid appearance with an invasive component right next door. So that's kind of another variant which you may come across. And then you have the thing that sometimes causes us trouble here. You have what you can clearly identify as an ugly squamous cell carcinoma, invasive. No problem right here. You have this nice keratinization, focal, but easy to recognize as ugly keratinocytes, really jagged islands infiltrating with a desmoplastic response. So no problem recognizing this as poorly differentiated or moderately maybe differentiated squamous cell carcinoma. The problem is you don't really have connection to the epidermis. So then you have to think, well, could this possibly be a metastatic process? And in this case, it is. This is an example of metastatic squamous cell carcinoma. Sometimes we have trouble, though. It may not be possible entirely to tell if this is for sure a metastatic carcinoma or if you're just not seeing the connection. You can do a few steps through the block to look for it, but maybe it's just not present in the biopsy. So you have to at least raise the possibility in the report and say metastatic squamous cell carcinoma cannot be entirely excluded. And that's particularly the case if it's like head and neck, because oral squamous cell carcinoma can metastasize to an area of the skin around it, so around the head and neck. So if that's the area, you may have to really think about it and just leave open that possibility and just have the patient worked up for that possibility. All right. Okay, so now we're changing gears again, sort of. So we have this very keratotic lesion. You can see the red keratin right there. And at low power, I don't really think this looks very much like an atypical process, really, except for the fact that it's kind of complex. There are areas where there's some downgrowth. And then there's also one other thing. There's patches, little patches of lymphocytic inflammation. There's this saying that the lymphocytes are quicker at finding the cancer than the pathologist. So it's not 100%. If you see lymphocytes, start to think about whether something is really benign or not. But it's not always the case. But in this case, though, you do have such an extensive downgrowth. You see this kind of right here. It's what I call like bulldozing its way down into the dermis, that you have to think about verrucous carcinoma, which is what this is. So verrucous carcinoma is a low-grade, slow-growing, locally destructive process that rarely metastasizes. There's various clinical scenarios that you can associate with this. The oral cavity, you can have it in the genitoanal region. And in that case, you can call it the giant condyloma acuminatum of Buschke and Lowenstein, or you can have the plantar version. And there's this term called caniculatum, which is sort of describes these rabbit burrows, which you can see clinically. And that corresponds to what you see histopathologically as these downgrowths, which I was just talking about. So you imagine the neoplasm is sort of bulldozing its way into the dermis. And these are these sort of caniculatum, the rabbit holes that we here used as a descriptive factor. This slide right here just happens to have a lot of this lymphocytic inflammation as well. Again, that can be a clue to this process, to verrucous carcinoma. So you need a fairly large biopsy to get this, because if you don't get the base and you just get the surface, just because it's such a well-differentiated thing, You can easily call this benign if you just get the surface of this. So hopefully not making you dizzy there, but you get this, for example, superficial biopsy, you know, and you don't know the size, and you don't know anything else, you can go down the tubes. And if you don't see this part right here, which is really nicely represented, this bulldozer kind of part right here, where it's pushing its way into the dermis, you can miss it. So that's important. And I kind of summarize this right here. So just think about it. If you're even suspecting verrucous carcinoma, just make sure you get that large biopsy. Otherwise, the surface can resemble that of a wart, and it's a very well differentiated lesion. So that's why it causes problems. Okay. So we'll move on to something that can mimic verrucous carcinoma, but is actually much more common and much kind of has its own distinctive appearance. This actually lichen simplex chronicus, but I thought it was a pretty good representation of pseudoepitheliomatous hyperplasia. You also get this sort of downward growth, but not as extensive, not nearly as extensive as the bulldozer effect of verrucous carcinoma. And the areas of proliferation are generally centered around follicles. So you can get a lot of hyperkeratosis, a lot of hypergranulosis, and similar to verrucous carcinoma, you don't have any atypia. So you really just want to look for that extensive process in verrucous carcinoma to differentiate the two, the deeper process. So anytime you have pseudoepitheliomatous hyperplasia, you'll know that you want to look for an underlying cause. This is another example of LSC, like in simplex chronicus or prurigo nodularis. But you always want to make sure that there's nothing going on underneath. So you look for infectious processes, in particular deep fungal infections. You can look for tumors. The classic one is sort of granular cell tumor. Sometimes you can get pseudoepitheliomatous hyperplasia next to chronic ulcers, like in pyoderma gangrenosum. So it's important to keep that in mind. What lies beneath, I guess, is the issue there. But you can see the pattern here. This is sort of, as I was saying earlier, LSC prurigo type pattern. It doesn't have that bulldozer effect. I mean, you have thickened epidermis, but it's centered around follicles and it's sort of at one plane. It's not as irregular and as deep as what you were seeing in verrucous carcinoma. Going back to this other one. Same thing sort of here, even though it's cut off at the base, it still doesn't really have that deep extension. I think actually they did a deeper shave right here, which shows that it's not going any deeper. So that helps. Okay, so here we go into something very familiar, which you'll see tons of cases of, basal cell carcinoma. So again, we'll cover more of the variants, but I will say the kind of the classic things that you look for besides the basaloid morphology is that peripheral clefting artifact. Although I will say from the get-go that that is not 100%, you know, you don't always see the peripheral clefting artifact. So we talk a lot about it, but just because you don't see it doesn't mean it's not basal cell. So keep that in mind. Beautiful peripheral palisading here, and then really nice fibromyxoid stroma. So you get that in various kind of combinations, either fibrotic or mucinous stroma in the background. So you'll be seeing tons of these. So I won't go too much into this, but we'll talk about the variants. There's a nodular variant. So as you know, very common, probably one of the more common variants. And as the name implies, it grows like a nodule. So it's not too much more to say about that. Here's its cousin, the superficial variant, which is also very common. And I think of these as growing more like a pancake. So if you're looking at a pancake on edge, you see much more growth laterally than you do up and down. But still the same sort of thing. You still have the same basaloid cells, even a little bit of peripheral clefting artifact right there. And that stroma is so characteristic. I often tell residents that if you do, if we get a biopsy and it looks like this, let's say, and there's nothing, no basal cells on either side or anywhere, and you've cut through the block, you still suggest it just because this characteristic stroma is it's such a red flag for basal cell carcinoma. This really loose fibrotic stroma with vascular ectasia, maybe some inflammation. It's really characteristic. So I would say something that there might be a basal cell next door, even though we can't call it 100% on the biopsy. So sometimes you can have pigmented variants. So you can have what looks like, this is typically with nodular basal cell carcinoma, you have a very nodular growth. You have that nice fibromyxoid stroma, maybe a little bit of peripheral clefting artifact right there. And then you have little flecks of pigment in between as well. There's often this disconnect between how much pigment there is clinically and histologically, and it goes both ways. Sometimes I've seen cases where I barely see pigment and they're calling this thing rule out melanoma. They're obviously seeing something very pigmented, and vice versa. They don't see any pigment, and I see a ton of pigment histologically. So go figure. But in this case, no problem finding the pigment right here and right here. And as I said, sometimes these can be mistaken for melanoma clinically. So it's a nice way of kind of settling that issue. Very good example of the mucinous stroma here, pretty abundant. So sometimes basal cell carcinoma can get pretty ugly and can get very infiltrative, as we're seeing right here. Jagged infiltrative islands in some areas so poorly differentiated that it's even hard to tell or recognize as a basal cell carcinoma. And one of the things I like to tell residents is see if you can go away from the area where it's so ugly and maybe find an area that's a little bit more classic basal cell carcinoma, like maybe over here. It's not quite as poorly differentiated, although it's still fairly hard to tell as basal cell carcinoma, not like the nodular ones we were seeing, but I think it's pretty diagnosable right here. So morpheaform basal cell carcinoma will have that very, very fibrotic stroma, almost like a keloidal type collagen. I really like to see that as much as possible, that keloidal like collagen, before I call it morpheaform basal cell carcinoma. Here's another one that I think they labeled as desmoplastic. This one I think has a little bit better of that stroma, that keloid or bubblegum-like collagen intermingled with these atypical infiltrated jagged islands of basaloid cells. And again, if you have trouble finding or defining it as basal cell carcinoma, look at the periphery and then you see the more classic areas of basal cell carcinoma. Sometimes you can have a metatypical, or sorry, a macronodular variant. We'll get to metatypical in a minute. And a micronodular variant has, as the name implies, these small little nodules, these micronodules, go figure. So I think they should, what they're saying now, they should represent about 50% roughly of the biopsy before you call it micronodular, because it is regarded as a more aggressive variant of basal cell carcinoma, like infiltrative. And once again, if you have a hard time telling basal cell there, maybe go superficially, maybe go away from it, from the areas where it's really difficult to tell, and you might find areas that are more typical of just regular basal cell carcinoma, maybe over here, like in this area here, a little bit better. And this is a variant where we see in varying degrees and varying proportions. Again, periphery has the more classic areas of basal cell carcinoma, but then you go more towards the central areas and you can see almost like a keratinization in these sort of ovoid cells that I think have a more eosinophilic cytoplasm, almost a squamous kind of picture to them. So we see this, it's not too uncommon that we see this, what's called metatypical basal cell carcinoma, or sort of a squamoid differentiation, although usually it's in very small, it's a small percentage of the biopsy, whereas in this case, this is a pretty extensive example. So it's important to recognize it, because if you call something, if you don't have the classic areas of basal cell and you call this squamous cell or something like that, or undifferentiated carcinoma, and they go back and do Mohs or re-excise, and there's could be a discrepancy. So it's just important to be aware that this variant exists in case that does happen. Okay, so then we go on to my favorite one because it's so recognizable. This one has these interanastomosine strands of basaloid cells, which at this power, I think most people that are looking at this probably are either struck by it or know what it is. And the intervening stroma tends to be very kind of loose edematous or more fibrotic, not quite as mucinous as what you see in classic basal cell carcinoma. But you do have areas where it does resemble just classic basal cell, even a little bit of this sort of peripheral clefting maybe. This looks very basaloid to me. So this is a low power diagnosis. This is a fibroepithelioma of Pincus. often occurring on the trunks. But the classic is this long, thin, branching and anastomosing strands of basal cell carcinoma in a more fibrotic background. A very, very nice example. I will guarantee you you're going to see this either in your rotations or on your exams because it is just so distinctive. So be aware of it. Here's another example. Again, this one has even more fibrotic stroma, reddish type stroma compared to the last one. But what's common to all of these cases of fibroepithelioma pincus is these long internastomosing strands of basaloid cells. And if you have doubts, it's a basal cell. I mean, there was, I think, some question as to whether some people thought this was basal cell, belonged in the basal cell family or not. Although I think now it is, it's officially in the basal cell family. But this area, I think, looks very much like BCC right here. A nice example of fibroepithelioma pincus. Okay, so now we're going to shift gears and look at another fairly common thing that we see in practice, and which you will definitely see at some point. And one word I would use to describe this is crateriform. So we know it's a squamous proliferation. We can see this downward growth of squamous cells. We know it's crateriform. It's got this sort of volcano-like appearance, this plug of keratin centrally. So this is a nice example, a low-power diagnosis of a keratoacanthoma. So these are eruptive, or these can be eruptive. And they reach their full size in 6 to 8 weeks, involute usually by about 6 months. And it's important to recognize these. They're very common, but you can see them in certain clinical scenarios like immunosuppressed patients, and sometimes immunoturé patients as well can have this. You have giant variants, subungual variants, and you really shouldn't see much atypia. Similar to like Verruc's carcinoma, you shouldn't see much atypia at the periphery. I typically describe this as sort of a very glassy cytoplasm appearance to these squamous cells with minimal nuclear atypia. If you're seeing stark nuclear atypia at the periphery, you may want to rethink whether you're going to call it a KA or just call it a squamous cell. Although some places are kind of lumping these two together now, they're lumping KA under the family of squamous cell carcinoma. So you have solitary variants and you have multiple variants as well, which we'll talk about in a little bit. But first, we'll talk about kind of the lifestyle, or not the lifestyle, the progression of the life of these things. So KAs will, in the earlier weeks, will look like this. And as we know, they do involute spontaneously. So what do they look like when that happens? Well, they look a little bit more like this. Let me get the hold of this thing here. So they have more of this, a couple of things. They have a thinner wall, a thinner epithelial wall, and they have much more of this brisk host reaction. So you have much more fibrosis and a lot of inflammation and lymphocytes in particular. So two things happen. You get thinning of the wall, you get thinning of the overall lesion, and you get more of this inflammatory reaction to the point where it can almost be difficult to even recognize it as a keratoacanthoma as you move throughout its life here. Look at this area here. You can still here recognize it's sort of a crateriform morphology, but much, much thinner wall compared to the first one that we saw. And right here, probably about the thinnest wall that you can imagine right here. It almost looks like regular epidermis as far as thickness of the wall. And if we didn't have all this regression, all this inflammation, it'd be very difficult to tell this as a keratoacanthoma. Here is nicely represented. You can see the kind of the keratotic plug right here. So here we have a good example of a regressing keratoacanthoma. And then finally, I got one more KA to show you here. This one is basically on life support right here. It almost has like no thickness at all to the epithelium, but still architecturally recognizable as a keratoacanthoma. Sometimes if we get these, we have a hard time telling these from just keratotic lesions. Like, could this be a regressing wart or something? And it may be an academic thing because by the time they're at this point, they're almost completely gone anyway. So they're not going to do anything to the patient likely. But you still have that good stroma, that fibrotic stroma, that regressive type stroma, and that mixed inflammatory infiltrate that tells you that this is a regressing keratoacanthoma. You do have multiple variants as well. I mentioned them here. Well, here first we'll talk about the solitary one. I mentioned all these things so far. We just talked about the regression. And here are the multiple lesions, the Ferguson-Smith type, Grzyboski type, which you can look up interesting clinical scenarios, but I won't go too much into those. Okay, so we'll go on to our next case. So right off the bat here, let me flip the slide around. We can tell that this is actually a particular anatomic location because we have these things right here, these ducts. These are actually mammary ducts. And we have also, you can see them better down here. And they have that sort of apocrine differentiation. You see that right there? So we can identify them as mammary ducts. We know we're on the breast nipple location. We have smooth muscle, so it's nipple areola location. And we have ulceration of the epidermis, intact looking normal epidermis over here. And then we have the bad guys right here. So this is, if you remember, we were talking about the Bowen's disease or squamous cell carcinoma in situ. This is similar, full thickness atypia. But these cells, to me, look a little bit larger, maybe a little bit of paler cytoplasm. And if you're in this anatomic location, you really have to, of course, start thinking about what this is, which is Paget's disease. And this case also has cells, individual cells, demonstrating a pagetoid pattern of growth. So as you know, Paget's disease that occurs in the nipple or areola clinically can mimic eczema. And the most important thing, it's almost always associated with an underlying carcinoma. So it's very important to recognize it. You typically have a few things on your differential diagnosis with Paget's. I always tell residents that there's a few things. So you want to think about melanoma in situ, squamous in situ, of course, Paget's disease, and in some cases, even things like sebaceous carcinoma can have this sort of a pattern. So you may need your markers. Our go-to stain is cytokeratin 7, which stains very nicely both Paget's and extramammary Paget's disease. But you also want to do your melanocytics, maybe your keratin markers to rule out these other conditions as well. But the pattern is very important, this pagetoid pattern. Most of the time when you see it, it's going to be in the context probably of either melanoma or squamous cell carcinoma in situ, because Paget's disease is a little bit more on the unusual side. But you don't want to miss it, so important to recognize it. Before we go to this case, let me just show you the summary here. This is what we were just talking about. And really, again, the most important thing is almost always associated with underlying carcinoma. This contrasts with extramammary Paget's disease, which is what we're going to talk about now. So here we have another biopsy. I'll flip it over. That has this very, I think even better than the last one, better represented pagetoid pattern. And this picture right here is the best because we have a few things that I can point out. We have full thickness atypia, but we also have these, what I was saying earlier, these larger cells. As you see lots of squamous cells, lots of melanomas, you start to recognize there's something different about these cells. They're larger. They're not forming a typical nest like you would see in melanoma. And they're just really predominated by this pagetoid extension, these single cells that are going up. Not that these other conditions can't do it, but this really does it to an extensive degree. And the size of these cells is striking because typically the other conditions like melanoma or squame, the cells aren't quite this large. Of course, we do end up doing our immunohistochemistry because you really want to be sure of your diagnosis. And cytokeratin 7, as I was saying earlier, it's positive both within Paget's disease of the breast and also within extramammary Paget's disease. Here's another example. I think our first example was better, but this one still shows it. And you can also do a mucin stain. You know, you wonder why are these cells so large and pale? Well, if you actually do a mucin stain, these cells will light up like a Christmas tree. So that's another thing that you can use. Interestingly, this case, the Paget cells don't seem to be pagetoiding as well. They seem to be kind of stuck at the bottom. So just goes to show you that these things don't always read the books. Even in peripheral areas over here, I don't really see much. But still, you would see this pattern, this atypical intraepidermal growth. You have to think about those conditions I mentioned. And again, I still think that these cells, even though they're not showing the greatest pagetoid spread, have that large quality to them. So again, do your cytokeratin 7, do your cytokeratin or do your mucin stain if you want, and your negative markers for melanocytic and squame. So here's a little summary. So extramammary pages would definitely see this. Maybe see one case every few months. Vulva, male genital tract, perineal area, sometimes even the axilla. And that's because of the apocrine glands, which is thought to be a point of derivation for these things. Histology is similar to Paget's disease, and it may arise from an underlying adnexal neoplasm, probably apocrine in most cases, although in about 10 to 15%, you can have an underlying carcinoma, either rectum, prostate, urethra, cervix, or bladder. So that's contrast to Paget's disease, in which almost all cases you'll have underlying carcinoma. You still have to work up these patients, so that's important to know. So there we go. That's, I think, our last slide, and I hope that was very helpful. Sorry, I hope I didn't go too fast over the slides, but there were so many I didn't want to make this lecture 6 hours long. But I hope that was helpful, and I tried to point out all the salient features. And we'll continue these lever chapters, and hopefully they'll be of help to you. And thanks for joining, and stay safe.